now we're talking about impulse control disorders. Um, so we are going to talk about a few different ones. The first one being oppositional defiant disorder, or AKA Courtney. This is what Courtney showed us during our mystery psych patient party. I always would say go ahead and take a look at the DSM-5 criteria for these disorders, because that actually will highlight how long it has to be in place. We all have times where we're angry and irritable and not feeling like going along, right, with the program. And that's not an oppositional defiant disorder. This is something that lasts more than 6 months. It's affecting their daily life. It's defiant behavior, often seen with ADHD at times. Again, chicken and egg, which is causing which. And when you see this in children, typically it's around 8 years of age they're first diagnosed. You really need to start looking at what's going on with this child and really trying to intervene as soon as possible to do whatever you can to help. So it can be caused by genetic factors, all different kinds of neurobiological causes. What's going on with this child? What is their environment? What does their family structure look like? What is their socioeconomic status? Where are they living? Are they living in a car? There's so many different things that can play into this. The FDA has not approved any pharmacological interventions. However, meds that are often used to treat anger and aggression can be used for this, like Depakote is one of those. It's an anti-seizure medicine that's used for that. So that's our first disorder, oppositional defiant disorder. So now we're going to intermittent explosive disorder. And this is aggressive impulses that we see in adults that they cannot control. This is hard. If you have this, you're going to have difficulty with your interpersonal relationships. You may have trouble at work if that keeps happening. You may be getting in trouble with the law. Could you go hand in hand? Sure. A lot of these, like we said, aren't black and white, and they can kind of commingle with each other and be multifactorial. Again, comorbidity with depression, anxiety, and substance use disorder. Or is it, when I say chicken and egg, I don't mean that those would cause it, but I just mean because of this, are you acting like that, right? But maybe substance use disorder, though. We know those people who are angry drunks, right? And this, something like that that's happening all the time. Someone who is antisocial borderline personality, which we'll talk about next week, can also have this as a comorbidity with it. It kind of goes hand in hand. They have difficulty with interpersonal relationships. They have difficulty with boundaries. Therefore, they're going to have difficulty with impulse control. And all of this goes hand in hand in hand. Again, similar to oppositional defiant, there hasn't been a lot of meds. Oh, geez, sorry, I opened up my email. There hasn't been a lot of meds that have been approved for this. However, they use SSRIs on an off-label use. So that means when we say off-label, something that an SSRI hasn't really been studied at length with it. You have to have a lot of research behind a drug to say it treats a certain drug. But the thought process is maybe these people are having a little low levels of serotonin, and if we could get the serotonin up, maybe they wouldn't feel so explosive. So again, I think we could think of lots of different examples of this disorder. And then your third one is going to be your most serious. This is conduct disorder. And this is abnormally aggressive behavior. And this is really with people who were worried about, we're kind of going on the path of, sociopathy a little bit, right? Like they don't have remorse. They don't follow our societal norms and rules. These are people who steal. These are people who rape, things like that. Conduct disorder can lead to lots of problems. Juvenile, lots of these kids who suffer from this end up in juvenile court. And again, could you start with oppositional defiant and kind of morph into conduct? It's hard to say. They're a little bit similar in my mind. This is more of a childhood onset. You could have both. You could have childhood prior to age 10, adolescent after. And two problems you see a lot in children is pyromania, starts fires, and kleptomania, aka Mo, likes to steal. You were so good in that mystery party, Mo. But I think one of the things to think about with this is, what's happening? Why is this happening? If we see this in children, hurting animals, starting fires, stealing, it's not just someone shoplifts once because they're, trying it out as a teenager. That's a lot different than someone who is constantly, stealing, and it's a pattern. We're looking at patterns of behavior that is really kind of considered abnormal. What I found interesting is they found that it's fairly rare. Comorbidities are the same as kind of all the other ones, anxiety, ADHD, anxiety, all of those kinds of things. They see a lower heart rate and higher levels of testosterone in males. They also see very obvious structural and functional brain changes. And you don't need to know those by heart, what they are, but just that actually people with conduct disorder were seeing a change in their brain. Environmental factors, looking at all different kinds of things. What was this patient? Were they abused? Were they neglected? Were they possibly put in foster care or in some sort of institutional living early? There is lots of circumstantial environmental issues that can deal with this too. So as you can imagine, treatment is going to be multifactorial. You may need family therapy, but who knows, this family may have some antisocial personality disorders as well, or maybe neglectful, so that may not always be your best bet. But they're going to try all different kinds of therapies. And then, oh my gosh, sorry. And then also, these are treated, every pretty much psychotherapeutic drug out there, was listed under the treatment, from SSRIs to SNRIs to antipsychotics to all different kinds. So it sounds like they try all different approaches, probably depending on how this patient is presenting. All of these kinds of patients were concerned about suicide risk. You need to always be using validated assessment tools. If you look in your book, they actually have assessment tools which help differentiate between conduct and oppositional defiant disorder, and because they do sound very, very similar, right? So we're looking at oppositional defiant disorder. Oh my God, I want to make sure I say it right. Intermittent explosive disorder and conduct disorder. So this is looking at 3 different disorders, and we want to always use those validated assessment tools if they exist. Again, safety and suicide risk always come first. And your self-assessment. How are you dealing with these patients? These can be difficult patients to take care of. And so you really want to, do a self-check. And really you have to provide equal care to all people. You have to be empathetic. This is one of your responsibilities. And there's really usually tragic circumstances in the origin of these kinds of patients. And so if that can sort of help you to find that empathy, it's important to do that and to try to understand many of these patients are this way because of some pretty horrific experiences that have happened. It doesn't make that necessarily easier to deal with a difficult patient like this. But it can maybe help you to gain some understanding. So it's really important when you're dealing with these kinds of patients that you are doing your self-check that happens. All different kinds of therapies, this goes through all different types of things are used. And it's really important with these kinds of patients that you're looking at teamwork and safety, and that maybe you always pair up when you go in a room. These kinds of patients, because they're impulsive, it can be important to really practice a lot of those sort of safety issues you have seen, or safety principles and practices you've seen on the psych units that you've been on. Occasionally these patients do have to be in restraints. Occasionally they do have to be in seclusion, not only for the protection of themselves, but for the protection of others. And as always, everything we do in nursing always ends in what? Evaluation. We always evaluate what we do because we practice evidence-based practice, and we don't just do things. We evaluate and see, did they work? And that's how you individualize care as well, is you evaluate and say, did this work for this patient? Not just, does this treat this disorder? Does this actually help this individual patient? So, ta-da, I'm done. Happy weekend. Take some time out for self-care, and I will see you all Monday morning. Goodbye.